Hi again. In this last lecture of Day 4 of the International Aesthetic Masters 2017, we have to make an announcement. Maybe you have seen it already in the email we sent or in the message we sent by messenger. In fact, due to unexpected force majeure reasons, we sadly must announce that unfortunately my dear friend Marcelo Calamita won't be able to present today. In fact, we couldn't receive Dr. Calamita's lecture in time for this event. We will not let you down and we will make it up for it twice. Yes, on one hand, we are still arranging the best way to have Dr. Calamita's participation, not today, but soon. Make sure to attend my closing lecture this Saturday at 7:30 p.m. GMT, where we will be ready to announce it. And on the other hand, we wouldn't leave you today empty-handed, of course. So, I'm happy to present you a big surprise. Replacing Dr. Marcelo Calamita, we will have none other than my dear friend and great aesthetic master, Dr. Mark Bowes from South Africa. Mark was one of the masters to speak at the International Aesthetic Masters 2015, the first edition of this World Online Congress, and he kindly allowed us to share with you one of his best presentations: Minimally Invasive Dentistry, Why We Need It. Mark is a reference in this field and is the founder and president of the South African Academy of Aesthetic Dentistry. He is a renowned dentist, an international lecturer, and he was head of the organization of some major events such as IFED. Let's hear Mark talking about minimally invasive dentistry, which Mark says should be evidence-based and address both aesthetic and functional needs. Don't forget that tomorrow we will continue our intensive week starting at 8 a.m. GMT with Alessandro Pozzi from Italy. Enjoy and have a great night or day. See you soon.
Hi, I'd like to introduce myself. I'm Dr. Mark Bowes, and I'd like to welcome the whole world to Cape Town. It's presently 1 o'clock in the afternoon here. I believe it's 11 a.m. in London, 5 p.m. in Beijing, and I'm sad to say in Los Angeles it's 1 a.m. So guys, stay awake, it's going to be worth it. Firstly, I'd like to say a massive thanks to the International Aesthetic Masters team. Great vision, passion. I know you guys have given up a lot of your time to put together this absolutely amazing meeting. We have 39 presenters representing 19 countries. I'm the only representative of Africa, so I have a massive weight on my shoulders. I'd just like to apologize. The last week I've had bronchitis, but absolutely wouldn't have missed this for anything. The good news is I have a couple of cans of Red Bull to keep me through the next hour, and I'm sure we're going to have some fun and learn a whole lot of stuff. First thing I'd like to do before we get started is just to take a picture. I believe there are 100 countries, or even more than 100 countries, so I'd like to take a picture of all of us together before we start. So thanks so much for that. Right, so today my topic that I'm going to be talking about is minimally invasive dentistry, or more importantly, why we need it in our practices. I have a wealth of experience. I've been practicing for more than 30 years, and there's no question that the last 10 years has brought about the biggest change in the way we treat our patients and the way we manage cases. And I think that the minimally invasive concept basically has allowed us to be much more conservative but achieve better results. And this was always the dogma with regards to dentistry, is that in order to achieve beautiful results, we really had to destroy a lot of healthy tissue. And I'm going to show you from an evidence-based point of view how actually I've incorporated the minimally invasive dental concepts into my restorative practice. I'm going to start with a quote from South Africa, the most famous South African, no question, the iconic Nelson Mandela, who was sadly held in Robben Island, which is only a kilometer away from where I'm sitting now. And after he was released, he said it always seems impossible until it's done. And I think this is the case, how we feel sometimes with our patients when they sit in our chair with some challenging problems that we need to manage, knowing that we have to do it in a way that's going to be sustainable in the long term. And I'm absolutely sure over the next hour, some of this puzzle is going to be solved for you guys, because all too often I've heard from dentists about minimally invasive dentistry. It doesn't work, it's too difficult, it's unpredictable. I'm going to show you that with the right protocols, absolutely this is not the case. So we have a theme for this presentation. We have a theme that we're going to follow through the hour, and that theme is to treat the problem and not the tooth. And essentially this is what's changed in the last 10 to 15 years, because I think previously it was exactly the opposite. We used to treat the tooth and not the problem. And it's a little bit confusing to you maybe now, but I'm sure you're going to understand where I'm coming from when I say please treat the problem and not the tooth. So one thing for sure, if you're going to go down this minimally invasive road, is that we need magnification. I'm not going to spend time about what magnification, but we need to see better. We need magnification. In my practice, I use loops. I have 4.3 loops for Moroscoptic with an LED light and a microscope. And I have to say I love both, and really without them, there's not, what you're going to see later in this hour is just not possible. So we have to embrace the magnification factor. There's no question about that. We're going to start with a case, interestingly enough, of what you shouldn't be doing. And this was classically a case where this patient had the teeth treated and not the problem. And she was a friend of mine. She plucked up some courage. She came to see me, and I know the history. And she had informed me that about 15 years ago, she was fed up with the crowding in the front of her mouth, and someone said, that's no problem. We can do some crowns and we'll fix it. And so he fixed it in the short term. But what we're going to see is that as things unfold, we're going to have massive problems and massive failures. And looking underneath those crowns, you can see the damage that was done. And we're going to pick up this case later. From a minimally invasive concept, I suppose that the endo access was minimally invasive, as you can see here. But apart from that, pretty much those teeth were destroyed. And we'll come back to this right at the end of the presentation. I'll show you how we managed this case. So I think it's terribly important that we really have the ability to try and describe what it is we mean when we talk about minimally invasive dentistry, because it's kind of a loose term. Alessandro de Vigas, who's the chief editor for the International Journal of Aesthetic Dentistry, wrote an editorial about 2 journals ago on minimally invasive dentistry. And in his words, he summed it up beautifully. Minimally invasive dentistry is the application of a systematic respect for the original tissue. And during the thread of that editorial, 3 things really came to light. The first was prevention. You know, prevention really is the go-to means of treating any dental problem. Secondly, tooth preservation. We have to look after what is there, because that ultimately is going to provide the success and the predictability of the dentistry we're going to do for the patient. And the third is really an interesting concept, and we're going to develop this as we go through the lecture as well, which is one of controlled failure. Sadly, the reality is most of the dentistry we do for our patients is going to fail. It's not what we want to tell them, it's not what they want to know, but the reality is a lot of it is going to fail. And so I think the concept of controlled failure is a great one, because really there's two possibilities. Either the biology fails or the dentistry fails. And if we're planning for failure, it means that when that failure arrives, we have a further solution that's going to be agreeable to the patient and the tooth. So this concept of controlled failure will crop up again, and I think it's a great term. So I'm lucky enough, as you know, from Cape Town. I practice in, no question, the most beautiful city in the world. Just above that stadium is where my practice is. And I'm going to take you into just a few cases that walked into my practice looking for some help over the last 6 months. And what we see is tooth wear cases. And tooth wear has become a massive problem in dentistry, and certainly where I practice, we see a lot of it. And the worrying thing, as you see there, is that the average age of these patients is 31. So, first of all, there's no question these patients need treatment. If we leave these teeth untreated at the age of 31, there's a disaster. Secondly, we have to provide the patients with some form of treatment, and if we go back a couple of slides, where we're allowing the opportunity for a controlled failure. In other words, if our dentistry fails for these patients, it's going to be able to be redone, because at the average age of 31, there's no question that a lot of it will need updating as they get older. So if we look at tooth wear, I think that there's some interesting things that we need to understand in managing these patients from a minimally invasive treatment concept. Is the first and the most important is we need to make a diagnosis. We can't move on to any treatment or any treatment planning until we've diagnosed the problem. We have to have a massive understanding on prevention, because at the end of the day, if we can avoid treatment, obviously this is the route to take. In treating a lot of these tooth wear cases, certainly the more extensive tooth wear cases, when we're planning them, we also have to have, and you'll see in the cases later on, that we have to have a good understanding of vertical dimension of occlusion. Of course, we need to be competent at dental treatment. You know, I think this goes without saying, restorative treatment. And what do I mean here? I mean tooth preparation, I mean impression taking, temporaries, bite registration, cementations. You know, this we kind of take for granted, and we'll cover it a little bit, but obviously it is a really important part of treatment of our patients. And then possibly the most important part of this whole process is what comes at the end, and that's the monitoring and maintenance, because relapse of these patients is a big risk. So the one thing that I've introduced in my practice that allows me to work in a minimally invasive way, which is predictable and easier on my patients and myself to get the sort of results we're looking for, is the use of bonded transitional restorations. And it's the thing that I would like to try and show to those of you who are listening, how we use these bonded transitional restorations to manage what would otherwise be unbelievably difficult cases. And we transform them into really simple methods of helping patients achieve the sort of restorative stability that they need. So I think it's important that we look at the differences between conventional and adhesive restorations when we're talking about minimally invasive dentistry. So conventional restorations remove a lot of tooth structure during preparation. We know this. There was a beautiful study by Daniel Edelhoff and Sorensen, and they found between 63 and 72% of the coronal tissue was removed during the preparation of a tooth for an all-ceramic or porcelain-fused to metal crown. And that amazed me. When I read this article, I couldn't believe it. That's a lot of tooth being removed. And not surprising, the second point, conventional restorations run a high risk of pulpal problems. We're not surprised if we remove 72% of the tooth structure. Saunders and Saunders did a study in '98, and they looked at a vast number of Panorex x-rays, and they looked at all the teeth that had full coverage restorations, and what they found is that 19% of these teeth, of these full coverage crown teeth, had signs of periradicular disease. That's another big concern. Conventional restorations have a high cost. Yes, they have a high cost on a financial basis, but for me the high cost really isn't from financial, but it's the biology. I think it's the biology, the cost to the patient is what's been taken away from them. Adhesive restorations are technique sensitive, yes they are, I agree, but with the sort of protocols that we're going to see, suddenly the technique sensitive side becomes not so much of an issue, and we can manage them in a much easier way. Conventional restorations have better longevity, I'll agree, but face catastrophic failure. And going back to Alessandro's editorial, this is the big difference between conventional versus minimally invasive, is that what happens when these restorations fail. On the one hand, we have catastrophic, and on the other hand, we have a controlled failure. I know which one I would prefer. And adhesive restorations, and this is probably the most important, adhesive restorations require enamel for predictability. So that's going to crop up again a few times. So if we looked at conventional and adhesive and we put all the good things together and we came up and we said, okay, this is a wish list, this is really what we need, a material that's going to help us from both sides. I think that it would have to be highly aesthetic. We live in a highly aesthetic, and our patients have a high aesthetic demands. It needs to be minimally invasive, no question. We know about what the biology of taking away tooth structure does to a tooth. It needs adhesive capability, high strength and durability, low cost, but for me, low cost rather to the biology, not to the pocket. Low wear on the opposing dentition. It needs to be biocompatible, and really importantly, it needs to wear similar to enamel. And before I move on to the next part of the slide, I'd just like to say that I don't get paid by any dental company. I choose materials which are best for my patients and best for me. And I'm pleased to say that in my practice, this material actually exists. I've been using lithium disilicate for a long time, and of all the materials over the last 30 odd years, I think singly this is possibly one of the materials that has changed most of my dentistry. So if we're talking minimally invasive dentistry, we need to be proficient at certain procedures, or we need to understand the use of certain procedures. And those procedures to me are whitening, orthodontics, periodontics, resin restorations, direct and indirect, and ceramics indirect. And I suppose that when we start at the top and we go to the bottom, we're starting at the least invasive and we're going down to the most invasive at the bottom. So tooth anatomy becomes a really unbelievably important topic if we're talking about minimally invasive dentistry. And we have to have an understanding certainly on the enamel thickness and what happens to the enamel as we age. We also need to have an understanding on the pulp, the CEJ, and occlusion. But it's the enamel that really is important. If we're trying to preserve the enamel during any restorative procedure, we need to know how much is there. And I do a lot of teaching, and over the years, I have to say not one dentist has given me the right answer to this question. And the question is, what is the thickness of enamel on a central incisor at the gingival third, the middle third, and the incisal third? I'm about to give them to you. So in the gingival third, we have 0.3 to 0.5. In the middle third, we have 0.6 to 1 millimeter. And in the incisal third, we have 1 to 2.1 millimeters. The real problematic tooth is the lateral incisor, because if we look at the gingival part of the lateral incisor, we have 0.2 to 0.4 of a millimeter. And if we need the enamel for predictability in our restorations, if we remove more than 0.4 of a millimeter at this area of the tooth, we're into the dentine. And suddenly the predictability of the restorations is going to be in question. Of course, we need to know that as the tooth is getting older, we're losing the enamel. And in tooth preparation, we need to understand facial contours in the middle, incisal, and third. So I think that we don't need to argue the benefits of supragingival margins. I think they're clear for us. but I'd like to just list them for you again. And if you look at this tooth that I've prepared, this is a standard tooth preparation for me in my practice these days. And really what supragingival margins allow me is way easier preparation. I can actually see exactly where I'm preparing. There's absolutely no damage to the gingiva, as you can see in this case. It's far easier to take an impression of this tooth. We get better bonding because we're bonding only in enamel. It's much easier to get moisture control during the cementation process. There's less micro leakage for the two reasons above. And of course, there's no biological width issues. So let's look at the cost. And we've been on about this. The cost for me is biology. It's the biological cost to the patient when we go through conventional tooth preparation. And this is a case, this is a second full mouth rehab that this patient had. I can tell you that the third rehab that they're going to need is going to be a full implant supported prosthesis. And clearly these are cases that we don't want to end up in our practice. So what's changed? What's changed in the last 10 years that's allowed me to practice in a minimally invasive way that's predictable, that I can achieve the aesthetic results that I need for my patients? We have a high demand, and that has taken the stress out of doing the dentistry. So I have a list of things that in my practice have changed. The first is digital smile design. Thanks to Christian Coachman, who's on the panel of lecturers later this week, and I urge you to listen to him. But I've done many cases now, and you know, digital smile design is really the starting point of the restorative treatment plan. It's a facially generated treatment plan, you know, other than just a tooth-driven treatment plan. So we start with the face, and we integrate the dentistry that needs to be done for this patient into their face. And it's a massive tool for us to communicate to patients and to the multidisciplinary team. Guided tooth preparation. We understand now the need for enamel. We have to be able to control our tooth preparations, that we have enough space for the ceramic, but we haven't taken away too much tooth structure so that we still have predictability. Of course, adhesive cementation has got easier and easier over the years, and the bond strengths are great, and it's more predictable. For me in my practice, and this is what we're going to talk about during this presentation, is the use of bonded transitional restorations have allowed me to develop changes and be able to confirm the changes are right before we move on to any definitive restorations. And the last, and you know how I feel about Emax or lithium disilicate restoration. So that's the list of things that I look at and say, and I suppose I could add magnification to that list as well, that have allowed me to change completely the way I practice dentistry. Right, we're going to go into the second part of this presentation, which are the case studies. And really what we're going to do is we're going to take a lot of the information that we've been through in the first part of the presentation. I'm going to add to that some papers that were written by probably some of the most influential restorative dentists in the last 10 or 15 years, and show you how putting this all together from an evidence-based point of view, I make clinical decisions in how we treat our patients in the practice. So I'm coming back to join you guys. I hope you're enjoying the presentation. I'm feeling great. So let's crack on. The first case is Justine, and you'll see at the top there again the theme is going to be that we're going to treat the problem and not the tooth. And her main complaint when she came to see me, she was unhappy with her aesthetics, and she was concerned with sensitivity to temperature. But more importantly, she was concerned that her past dentistry was failing. And when I had a look, she had had a full mouth composite or resin rehabilitation due to a wear problem that had occurred in her teens. She was now 26, and she was looking to me for something that was going to take her and be more permanent than what she had had. And I have to say that the decision to do a resin rehabilitation was absolutely the right thing. It bought some time for us to make these decisions, and 100% what had happened is that preparation for a controlled failure had allowed us now to make some decisions to move forwards. So intraorally, if we look, what we see is we see a lot of wear, multifactorial wear, mainly erosion and attrition, but every tooth, absolutely every tooth, has a failure in resin restoration and some signs of further erosion taking place. We can see that nicely on the occlusal surfaces and the palatals of those upper anteriors. So again, I went on this. I went on about this earlier on when we're treating tooth wear cases, that we need to make a diagnosis. And in Justine's case, the diagnosis was severe generalized tooth loss. She had excessive wear without loss of vertical dimension, but with limited space. So these are challenging cases because we need to find space for our restorative work. I have a very strict treatment workflow that we go through in all these patients, and really it doesn't change. The first part is the gathering of information. We're talking dental history, medical history, we're talking digital photography, digital radiography, and once we've got all this information, we go to this digital smile design. The DSD is the starting point of the restorative treatment plan. It's a facially driven treatment plan, which obviously in the last few years Christian Coachman has been an amazing ambassador in developing a project and really taking the 2D element of smile design to the 3D, and I'm sure he's going to talk about that in his presentation. It's definitely worth listening to. But the digital smile design, the DSD, allows us to analyze the case and start to make the clinical decisions that are going to move us forward. So that goes off to the lab. And the laboratory provides us with a very accurate wax up, which is based on the DSD. We then take back it to the patient, and really the mock-up is a part of the treatment that allows us to confirm the changes that we're going to make to this patient in a functional and an aesthetic way. Once the mock-up has been agreed, we can move on to the bonded transitional restorations, and this is really the area that's really helped me with probably what would have been otherwise some of the most challenging cases: full mouth, minimally invasive rehabilitation. Once we're happy with the bonded transitional restorations, and we have massive flexibility on the timing of this, but once we're happy and we've confirmed everything from a functional and an aesthetic point of view, we can move on to our final ceramic restorations. So, as I say, I've already mentioned Christian's name. And as he puts it, the goal is to design a smile that fits the patient's functional, aesthetic, and emotional needs by improving team communication and a real interdisciplinary treatment plan. So essentially, we need to look at the face, we need to analyze the face, and we need to draw some lines to start making some decisions. The DSD, we go through, we work on an intraoral photograph that's aligned to the bipupillary line, and we start to look at what changes are going to be necessary in rehabilitating a case like Justine's. And what we see from this is that there's going to be quite a lot of changes on one side in terms of adding hard tissue, and on the other side we're going to have to rearrange the soft tissue. So once this information has been done, it gets transferred to the mock-up. We go to the patient, we transfer this into the mouth, and we start to confirm these changes with the patient and with ourselves and the laboratory. So these are the pictures. There are a series of pictures that we're going to take that are going to help us feel comfortable with the changes we've suggested. In this case, we needed, obviously, as you can see, to do some surgical crown lengthening. The crown lengthening guide was driven by the smile design, so we have a template which is developed from the smile design from the wax up, and from the wax up to the surgical guide. And you'll see that we work very, very accurately, very detailed. And this was a complex case because each tooth needed a slightly different amount of soft and hard tissue adjustment because we had a big cant going from one side to the other. But it's absolutely driven by the DSD. That was 10 days after the surgery, And the one thing that you see is that fading resin restorations and chlorhexidine don't go well together. So it was time now to move on to the bonded transitional restorations, and I'm going to show you how we fabricate them in a minute. But why do we need bonded transitional restorations? Firstly, we need to confirm changes in vertical dimension that we're going to make for these patients in order to get space for the restorative work. Secondly, we need to confirm the aesthetic changes that we're suggesting to the patient. We need to confirm changes in the anterior guidance that we're creating for these cases, which are absolutely essential to the longevity of our restorations. It's a reversible treatment. You know, in the past, provisional restorations meant cutting teeth, laboratory fabricated restorations, and it was an irreversible process and an expensive process. And the really cool thing about bonded transitional restorations is that there's really a low cost, and we can delay the final treatment to when the patient and when we're ready to go on to the final process. So in a case like Justine's, she had obviously occlusal plane problems, and the bonded transitional restorations essentially are a fill-in transfer into the anterior section via a stent, and on the posterior you can see that we use laboratory cured resin platforms which are reinforced with fiber, and they're bonded to the teeth. We sandblast the teeth and use a self-adhesive type cement like Real-IX, and you'll see in her case that we wanted to correct the occlusal plane problem. So you can see that we needed to lengthen or add on to the upper left, and we needed to add to the lower right. And as you'll see, we've gone lower right and upper left, and then we just transfer this to the mouth. In the anterior section, we use a silicone stent with an outer acrylic shell, and a really cool material that was developed by Ed McLaren in Los Angeles from Bisco called Reveal. And it's a great material because it's kind of in between a flowable and a conventional resin material. But the beauty of it versus a normal flowable is it's nano-filled particles, which allows us to really polish it beautifully. And it has a much higher strength and it's more durable, meaning that it can last much longer. So here's the case. We started like this, and I think this case took about 1 hour and 10 minutes. It's really a kind of temporary full mouth rehabilitation, 1 hour and 10 minutes, no anesthetic, just an additive process. In these wear cases, 90% of the time, we're just replacing what was missing. And you can see actually in this case, we didn't have access to Reveal. This was an early case. And you can see that the material, and compare it to the next cases, that it didn't polish as well as the Reveal. And you'll notice that when I show you the next case. So again, we're just confirming everything that we've suggested, that we've analyzed through the design and the wax-up. That was pre-treatment, mock-up, and bonded transitional restorations. And everything looks exactly the same. Once we've agreed the mock-up, we can take this through to the bonded transitionals, confirm this, and go on to the final restorations. So with the bonded transitional restorations, we have really some flexibility about how long we want to leave them, depending on the patient's need to get onto the final restorations, financial constraints, time constraints. In this case, after 3 months, we were happy with all these changes in video and aesthetics, and we decided to go on to do the final restorations. And the cool thing is you don't have to treat the whole mouth. So we did it in sections. Essentially, we'll do the posterior right, finish that, posterior left, finish that, and then the anterior. So it makes the whole process from a restorative point of view much more simple, because essentially all we're doing is copying the video and aesthetics of the bonded transitional restorations. So the first paper that I'm going to encourage you to download and read is a paper written by a good friend of mine, Philippe Garel. Again, Christian's name crops up a lot in this presentation, and Marcelo Calamita. And the title of the paper was The Influence of Enamel Preservation on Failure Rates of Porcelain Laminate Veneers. And I apply this to any partial all ceramic restoration that I do, because it's a similar concept. And what they found is that they found a 99% success rate if the preparation was limited to enamel. And they found also that if the preparation of the restoration, the margins were limited in enamel, it was 94%. So these are extremely high success rates, and we have to take notice of that. And the key is obviously preservation of the enamel. So this was the posterior preparation. We decided to go full coverage because we had obviously erosion on the buccal and lingual surfaces, and she also had some interproximal decay issues, so we needed full coverage restorations. Again, the preparation was based on a beautiful paper that was written by Cortellini and Canale, titled Bonding Lithium Disilicate to Feather Edge Tooth Preparations in the Journal of Invasive Dentistry. And their preparation design was 0.3 margins, 0.5 on the axial walls, and 1 to 1.5 millimeters of occlusal porcelain. And so I think that you'll agree to me that these sorts of preparations are very different to the conventional crown preparations that we're used to. And really we preserved all the enamel that was left on these teeth. Those were the ceramic restorations look like, and they look fairly vulnerable, but I can honestly say that once these are bonded to enamel, and if the substrate that you're bonding onto is enamel, suddenly they become unbelievably predictable and unbelievably strong. The second paper that we're going to look at is the comprehensive and conservative approach for the restoration of abrasion and erosion. And this was written by Didier Dici in the International Journal of Aesthetic Dentistry. And one of the things that really I took out of this paper, and it's a beautiful, and I encourage you to read it, is one general principle governs all clinical decisions, namely to be conservative and therefore preserve tooth biomechanical status. So really don't interfere with the tooth if you can help it, or interfere as little as possible when we're preparing these teeth and restoring them. So in the anterior, thank you so much to Galip Girel for developing these guided tooth preparation protocols. It looks like we've been pretty heavy in the preparation, but please remember that there were diastemas amongst all these teeth. And these preparations, we really just removed the old restorative material and placed margins. And we use silicon indexes to obviously check that we have the right amount of space for the ceramic material, as you can see. So we work very accurately, and surprise, surprise, under magnification. It's not possible to achieve these sorts of tooth preparations without magnification. And again, I'd like just to highlight the quality of the soft tissue after we've prepared these teeth. So for sure, you need the right tools. We need the right burrs to carry out these sorts of preparations. I was very kind, very lucky to have Horiko allow me to design my own kit. And really, just very quickly, the reason that we have these burrs selected is because each burr will allow me to prepare a margin of a different size, as you can see. So if I needed a margin, for instance, of 0.6, I'm going to choose an 018 burr, which is 1.4 in width and diameter, and that will allow me margins of about 0.4, 0.5 to 0.7. So occlusion, and this is really a topic that we could spend the whole week discussing. So I'm not going to discuss the CRCO too much. I think that I use both of them depending on the case, but absolutely the guidance is crucial. All these cases need to be restored with a fully functional anterior canine guidance. And this is what's going to help protect our restorations long term. And you'll see that in Justine's case. And so here you can see the final restorations that we've placed. You can see the beautiful canine guidance. And I'm going to show a video just to show you how it works. So again, the mock-up, the bonded transition on the final restorations are all just a copy of each other. You can see we've changed nothing because at the mock-up we were happy with the changes in aesthetics, the changes in guidance, and the changes in the vertical dimension. Some big soft tissue changes and some big changes in adding to the incisal edge on the left side. And again, before and after, and this was a challenging case, I have to say, but we ended up with a really nice result. And really, because we did it in sections and we allowed ourselves the ability to use the bonded restorations, it took a lot of stress out of this case. The really cool thing with the x-rays for me, and I have a look at the x-rays, and we can see that actually we've not removed any tooth structure, and there are the restorations sitting on each tooth. We have to thank Pascal Magna for all the work he did 10 or 15 years ago regarding the biomimetic principle, because he really started this whole minimally invasive crusade. And what he said is that the new restorative approaches do not aim to create the strongest restoration, but rather a restoration that is compatible with mechanical and biological properties of the underlying dental tissues. That was back in 2003. So what you see here is not the strongest restoration, but what you see is a restoration that is replacing what's missing, the enamel, and protecting the underlying structures, which is the dentine and the pulp. And 100% this case is what I would call a controlled failure case, because if something fails here, it's not going to be the pulp. It's going to be the restorative work. And yes, we can replace that down the line if need be. So I'd like to just play a little video for you of this, just to sum up the case that we went through. So let's move on to case number 2, which is Adrian. Adrian came to see me. He was unhappy with aesthetics, and he was concerned also about sensitivity to temperature. But he put his case beautifully in his own words. He said, "Mark, I'm concerned that my teeth are disappearing," which absolutely was right. So intraorally, what we see is again an erosion case, multifactorial erosion and attrition in his case. His diagnosis was severe generalized tooth loss. Excessive wear without loss of vertical dimension, but with limited, and in his case actually he had no space for restorative work. He had an edge-to-edge traumatic bite, and yeah, we needed to make some decisions for him regarding vertical dimension and what sort of restorations we were going to do. So the treatment workflow was the same as for Justine. We went through the same processes as we do for all our patients. It's the only predictable way. The DSD obviously gives me an idea of the soft tissue being in a good shape, but obviously he clearly needed lengthening of his teeth, and an edge-to-edge bite, the only way to do this was to increase the vertical dimension of occlusion. So we went through the mock-up, we checked aesthetics, we checked phonetics, we checked occlusion, we checked all the things that need lip support, buccal corridors, incisal edge position. We monitor, we confirm all of those things, and when we're happy with the mock-up, we moved on to the next stage. But sadly, that next stage didn't happen because he went missing. And about a month later, I got a call saying, "Mark, I've made the worst decision of my life. I went to see another dentist." Sadly, this dentist didn't understand minimally invasive treatment concepts, and he prepared a whole quadrant for full coverage restorations. Probably the worst dentistry I've ever seen in my 30-odd years. Anyway, I said, "Come on back and let's get you back on track." In the back of his mind, during our treatment planning appointments, I explained the concept of, I'm going to give you back what you've lost. I'm not going to take away anything more. And so from a radiographic point of view, I was horrified when I took a picture of these prepared teeth, and I suppose after reading the Daniel Edelhoff paper and Sorensen explaining that in a full preparation, we're going to remove more than 75% of the tooth structure, and that's what you see here. And there's no question these teeth, I'm sure, will be heading for endodontic treatment. So we moved on to, after agreeing on the mock-up, to the bonded transitional restorations. I'm going to show you a little bit more. Here you'll see these were the full preparations that were done, that we're going to make full coverage transitional restorations. But on the lower model, you'll see I've absolutely done nothing. I've taken an accurate impression of the teeth exactly how I found them. And the transitional restorations are going to be fabricated in the laboratory, heat-cured heat-cured resin reinforced with a Ribond or fiber tape. And we sandblast the teeth, Real IX, Unicem, self-adhesive cement, and these things absolutely don't break. So after the posterior transitional restorations were on, we obviously had what we wanted, which was an increase in vertical, which had been predetermined in the laboratory, and we were ready to do the anterior bonded transitional restorations through the silicon stent that we're going to make. So the third paper, I think, is a really good paper for you guys to read. Is a paper by Frank Spear in the Journal of Advanced Aesthetics and Multidisciplinary Dentistry, and it's entitled Approaches to Vertical Dimension of Occlusion. And apart from many things, what he said is there are multiple acceptable vertical dimensions at which patients can be treated. And really an interesting and really important another concept was that if patients' posterior teeth are unworn and in occlusion, all these patients can be treated at existing vertical dimensions. So you don't need to start treating teeth that don't need treatment. In other words, treat the problem, not the tooth. So that was the transfer jig or transfer stent that we made with the soft silicon and hard acrylic. That's the etch pattern that we use. We always leave the perimeter out because that's where the margins of our preparations are going to go. So we don't want any bonding in that area. If you don't want staining, you can use a kind of self-etching type material, but absolutely no phosphoric acid. That's what it looks like. As soon as it comes off, that's what it's like. And it takes, with a scalpel and some polishes, it takes about 10 minutes to get these teeth looking perfect. So Adrian came in, he looked like that. I didn't pick up a burr, we didn't use any local anesthetic, and about an hour later, we're done a transitional full mouth rehabilitation. So we took him from there to there. Now you can see the difference between this, the last bonded transitional material and the reveal material, how beautifully, because of the nanotechnology, how beautifully it polishes, and the increase in vertical that we have. And now we can check all those parameters of aesthetics and occlusion, function, and guidance. We've been through that. And so, again, we're going to treat the problem, not the tooth. So these teeth have been prepared for the ceramic restorations. These ones had existing resin restorations that were removed. The teeth were smooth, and that was it. It couldn't be easier, to be honest with you. We use these very cool interocclusal checks, just that we have enough space for the ceramic. And this is a little transfer jig. Because these ceramic restorations are very delicate, very thin, it's very difficult to do try-ins. So sometimes the only time you're going to have to check the occlusion, check the bite registration, is once they're bonded. And often, you know, that might be too late. So we make a really cool thing called a transfer jig. We mount the models with the transfer records that I've given the laboratory, and he makes this pattern resin jig, sends it back to me, and I confirm that the models that he's working on are exactly like what we have in the mouth. And if that's the case, we can go on to fabricate these restorations. So the placement of these sorts of restorations, it's full adhesive protocol. We need rubber dam, we need moisture control. And so rubber dam along with magnification are unconditional in my practice. Our cement options, for me, total etch resin cements or the adhesive, using full adhesive protocols are the only option. I'm not prepared to use any of those other three above. And my go-to, and again, this is not about products, but people ask me, what do you use in your practice? For me, this is the moment is the go-to cementation choice, the Monobond etch and prime, one liquid on the ceramic. It does the etching, the silination, and the bond, and the preparation of the bonding. And on the tooth, we just use etch in a selective pattern, whether it's a total etch, selective etch, or non-etch. But if there's enamel, I have to say it has to be etched. And we use Adhes Universal and then Verilink Light Cure or Dual Cure, depending on the thickness and depending on the restoration. So again, you know how I feel about controlling the tooth preparation. It's absolutely important, and what you'll notice, all these preparations are 100% in enamel. We have to give the laboratory accurate information, and that includes impression taking. He has to see everything that we see in the mouth. This is the way we do our shade taking. I'm a big fan of polarized filters and helping the laboratory in this process. And my ceramic of choice is Emax Press. We don't layer it. We used to layer a lot more. Today, it's actually seldom that we're going to layer these sorts of restorations. My ceramist, Shane Hansen from Diceram, is absolutely brilliant. And we can create the most aesthetic restorations in full pressed Emax, just stained and glazed. Of course, we need guidance. We've discussed this. For the longevity of these restorations, we need anterior and canine guidance. And we can take this patient in really a simple way from this situation to this situation. From this situation to this situation. And the lower anteriors, we decided not to do anything other than some clear aligners and some whitening. These are highly aesthetic restorations, you know, and obviously this is a guy, so yes, there's some staining, some edges that are not perfect. So this is the 6-month follow-up of Adrian's rehabilitation, and what we're going to see here is the beautiful integration of the soft tissue into the lithium disilicate restorations. And also, I believe, you know, the highly aesthetic ceramic that we've managed to achieve with monolithic porcelain. And obviously, the beauty of this is the increase in the strength that we have going forwards. I think this is a good opportunity just to mention a few things about these highly aesthetic, very thin lithium disilicate restorations, and that we have to have an understanding if we're doing this minimally invasive dentistry, in the relationship between the ceramic, the color or the color of shade of the tooth underneath, and the influence that the cement might have on the restoration. Because all these factors can play a big part in the final color or the final appearance of a ceramic restoration. And so it's really important that we have to have a firm understanding of these factors. And let me go through them once more. So the thickness of the ceramic, the color of the tooth underneath, and the influence of the cement that we use could have an effect on the final outcome of the shade of the tooth. So it's important that we also use a ceramist who also understands the influence that these factors can have on the final outcome. But I think you'll agree with me that you know, this is a beautiful result and highly aesthetic and highly stable. This is the transformation that we've made. And how do we do it? Why is it predictable? In my hands, because of the help with smile design, adhesive cementation, bonded transitional restorations, and Emax lithium disilicate restorations. So let's go on to the third case, which is Bianca, and her main complaint was that she was unhappy with aesthetics, and she's a high aesthetic demand patient. You know, she wasn't going to accept anything but the best. So when we took a look in her mouth, her teeth looked in good shape, I have to say. She had some anterior crowding in the lower, but when we looked at the palatal surface, it was a different case. And we've seen this article from Didier Dietschy about being conservative and preserving the tooth's biomechanical status. And when we looked at the palatal surface, we could see that she had no more enamel left on these teeth. So we needed to do something for her. And also she had worn the incisal edges down. So her diagnosis was localized tooth loss, and she had no space for restorations. But we knew from Frank Spear's paper that absolutely if the posterior teeth were unworn, we couldn't damage them. We couldn't utilize them in the treatment plan. So her options, we had to create space for her. So the only way we can create space is either with the doll concept or orthodontics. I've done many doll cases, but I have to say more and more I go to the orthodontic option because it's really a more predictable way of handling a case like this. We're going to create space orthodontically, and then we're going to use bonded transitional restorations for a slightly different use. We all know post-orthodontics, the teeth are unstable. We cannot go to the final ceramic restorations. She's going to have a retainer. So we use the bonded transitional restorations as a retainer and an ability to assess the aesthetic changes for this girl. And when we're happy and when the teeth are stable, we can go on to the final restorations. So from the DSD, we can see that there's quite a lot of tooth structure missing. We did the orthodontics, and how much orthodontics? Enough orthodontics just to create space for the restorative material. That's it. No more, no less. That was the wax up after the orthodontics. You know how we go through, the etch pattern for the BTRs, the bonded transitional. That was immediately after the silicon index came off, and this was about 15 minutes later. You can see we didn't touch these teeth at all, zero. And we took her from there, yes, she likes whitening, to there. And you can see again how beautiful this material polishes. From that to that. And so now the teeth are in a permanent or a semi-permanent retainer. They're obviously splintered together so they can't move. We're going to wait for the retention to be complete, and then we're going to move her. We're going to go through the normal shade taking process. Guided tooth preparation again. Clearly you can see this is totally limited to enamel, this preparation. Silicon index is to check we have space for the ceramic. Again, confirming, look at the etch pattern of these teeth. Absolutely just enamel. And again, these sorts of margins can only be created with magnification. And we know from Philippe and Christian's paper that if the preparations are limited to enamel, there's a high chance of success. That's what the restorations look like, very thin, 0.4, 0.3 of a millimeter in places. But when it's bonded to the enamel, these are absolutely going nowhere. From this to here, we obviously moved the lower anteriors also a little bit. We straightened them to create some space, and that's where we finished. Yes, she loves white teeth. It's not my ideal, but we had to give her what the rest of the teeth, or the shade, we had to match to the rest of her teeth, and she's a bleachaholic, there's no question about that. But anyway, a happy patient, predictable way of treating her, very conservative, and it has a controlled failure route somewhere down the line if that's the case. So let's have a look. The last case that we're going to discuss is the case number 4. And again, unhappy with aesthetics, high aesthetic demand. This patient came to see me. We start always with the DSD, and what we noticed here is we needed, yes, to add some length to these teeth. She had a resin diastema closure that we were going to deal with. But what I noticed on the canines is that they were quite buccally prominent, but we needed to add some material. So I didn't really want to do any buccal coverage because it would have created a bulky tooth, or I would have had to have been aggressive on my preparation. But I was a little bit suspicious, and when we looked on the intraoral, what we noticed is actually, this is in centric occlusion, that these teeth, she has an open bite here. So this was a perfect opportunity to treat a problem and not the tooth. So you'll see that in the anterior, we're going to deal with all these issues of adding ceramic to increase the length and to close the diastema. But on the canines, we're going to give her back some guidance that she was missing. So the mock-up, we were happy with the mock-up. We were happy with all the changes that we had made. The polarizing filters from Polar Eyes are amazing for shade communication. And then because of this paper from Philippe Garel and Christian Coachman telling us that the margins really of these porcelain laminate veneers need to be 100% in enamel, this is a situation that I prefer. So I'm not going to move my margin of the ceramic into the dentine there. I'm going to keep it in the enamel for predictability. And if it's a problem down the line, we can always bring the soft tissue down. So this is for me a much more predictable way of managing it than putting the ceramic somewhere down here. So I'd just like to move away quickly to another case that I treated about a year ago. Exactly the same problem, where we had the dilemma of where do we place the margin on this canine. And the problem that I was concerned with is that obviously this is a tooth that's going to be creating the guidance pattern for this occlusion. And if I had moved the margin of the ceramic beyond the CEJ into the cementum, I was concerned about the longevity. We have to understand that when we put loads on teeth, they flex. And most of the area of failure is going to happen in this part of the tooth. So I believe really the longevity of this ceramic veneer was going to be much more stable, having the margin placed in the enamel, where we know 100% that the bonding potential is at its best. And if we go through, we see the fit, just checking the fit of the ceramic. We bond it then using light cure cement, neutral cement. And what I want you to see is the sort of integration we can get if we're bonding these to enamel. And I believe this integration is the key to the long-term success of this tooth. When it flexes, as lateral forces are being put and they're transferred to the margin of this ceramic veneer, I believe because it's bonded to the enamel, we have the greatest chance of this restoration lasting long-term. And we can see the beautiful integration that we get with accurate ceramics and with enamel and with the light cure cements that we're using today. And I believe 100% this was the right choice in this situation. And from an aesthetic point of view, I think sometimes the compromise we feel is not really going to be there. And I think you'll agree with me that actually we get away with this, and I think the long-term now prospects for this case is really a lot better because of the subtle change in where we decided to finish the veneer. So again, here we're treating the problem, which is no canine guidance. So we're giving her back canine guidance. We're making some very beautiful, very thin ceramic veneers for the rest of the teeth, closing the midline diastema. And really, we've absolutely treated the problem and not the tooth in this case. And we had a beautiful result. Very happy. This was about 2 weeks afterwards, and for sure that papilla is going to grow back in. So again, an ideal case to highlight. And I'm sorry to just interrupt, but I'm a big fan of partial coverage ceramic restorations, and you can see the beautiful integration that we get. That's where that ceramic restoration finishes. So we've given her back guidance, which is key, and we've obviously dealt with all the aesthetic issues that she was concerned with. So again, treating the problem and not the tooth. So my personal experience with EMAX in the past 5 years, I thought I'd just have a look. This is absolutely not a scientific study. This is in my practice. 1,672 units were done, 531 crowns, 705 inlays or partial coverage restorations, and 436 veneers. And those were the failures we had. We had 6 which chipped. Those were all layered. So none of my full press EMAX lithium disilicates have chipped, and they were all issues with guidance. So we hadn't provided sufficient guidance in these cases. There were 4 fractures, and 2 of them veneers where we had prepped 50% of the dentine. We know from papers that that's not going to be adequate. Color problems, 3, 2 endodontic failures. Those were all retreatments, old full ceramic porcelain fused to metal crowns being replaced, and 3D bonds That was before we were using the current adhesive protocols and cements that are available. So all in all, a 1.1 failure rate over 5 years with over 1,600 units. So for me, that's predictable dentistry. And more importantly, the failure rate, be it low, is a controlled failure rate. And all of these, I can deal with them. So it takes me to the last case, which we started with, which is the highlighting of treating the problem, not the tooth. And in this case, the tooth was treated and not the problem. She had crowding. Her teeth weren't moved orthodontically. They were straightened with a burr. And she paid the price. So that's what they look like. You've seen that. You've seen what they look like underneath. She also asked that while I was fixing this, could we not fix some of the other issues that she had? So I said, sure, but you're going to see a totally different approach to how we tackle the aesthetic problems today compared to what happened when you had these teeth treated. We treated 6 teeth in all, and what you'll interestingly notice is that we have 3 conventional crowns, 1, 2, 3, those were the existing teeth. One of them is an implant abutment. So it's quite predictable when these sorts of preparations are done that they're going to need endodontics, and there's a high risk that that's going to be a catastrophic failure and we're going to lose the tooth and need an implant. The rest of them were minimally invasive, partial coverage, veneers, and you'll see that we took her from this situation. She only wanted the top left-hand side fixed from this situation to this situation. Very happy. 1 implant here, no prep veneer, partial coverage canine just to lengthen. You'll see there's the margin, and a partial coverage veneer on the 4 to address these issues. So this is a controlled failure area. This is a catastrophic failure area. Managed aesthetic problems managed in 2 completely different ways. And for those of you who are wondering which is the implant, it's that one. She wasn't interested in going through any further treatment regarding this soft tissue issue that she had here because it would have needed orthodontics, and she was totally happy. She had a low lip line and she was really happy and thrilled with the end result. So to finish off with, there's 2 single tooth restorations because we've showed just multi-restorations in patients. 2 upper left one, 2 ones needing treatment. Those are the final results. Both highly aesthetic, fully resectable, and 2 absolutely different ways of doing it. 1 ceramic on the left and 1 direct resin on the right. Whichever way you want, I'm happy. But for me, ultimately, what really excites me in dentistry is helping a patient like this, who has really some challenges with her bite, with the aesthetics, taking her from the left to the right without picking up a burr, through orthodontics, whitening, and bonding. And this really for me is the way forward for a lot of my patients. It's my go-to treatment choice. So an hour ago we started with this slide and it seemed impossible, but the good news is that it's done. I have a saying, you live by the burr, you die by the burr. And I'm hoping that for all of you who have been part of this presentation, that you now understand that the minimally invasive dental concept is no longer a myth but a reality. It's what our patients want, it's what our patients expect, and it's what our patients deserve. And please remember the concept of controlled failure. I'd like to take this opportunity to say thank you so much to the International Aesthetic Masters team for giving me this honor and privilege to represent the African continent. I hope I've done our continent proud. Cape Town is the most beautiful place in the world, so please, if you're here, pay me a visit. And just one more big thank you to everyone. You have a week of fantastic lectures ahead of you. So from Cape Town, I'd just like to say goodbye and good night and good morning to those of you where it's still morning. Bye for now.